Good afternoon, everyone. Today we are going to discuss some scenarios on female and functional urology. Thank you for the trainee who has given consent to record this session so that it will be a good revision tool. Your time starts now. You have a 55-year-old lady presenting with history of frequency and urgency symptoms in the clinic. How are you going to evaluate her?
I'll see this patient in a dedicated functional urology clinic where the urology nurse specialist is present, and where the patient will be asked to complete a 3-day bladder diary prior to the clinic and to arrive with a full bladder to provide urinalysis and residual bladder volume measurement. I'll then take focused history to establish what her predominant LUTs are between storage and voiding, any episodes of incontinence and the trigger for this, the number of daily micturition or incontinence episodes, and whether she's using any pads. I'll establish the level of bother and effect on quality of life, and if she's been tried on any medications. I'll establish her past surgical and urological history, and I will also establish her tobacco use and fluid intake. I'll then perform a chaperone physical examination, measuring the BMI in clinic. I'll elicit any abdominal or loin pain, tenderness, or palpable masses. And with the patient's verbal consent, I'll perform an internal vaginal examination to look for evidence of atrophic vaginitis, any pelvic organ prolapse, urethral diverticulum, and also the neurological sensation through the perineal examination.
How will you do a vaginal examination?
So I'll place the patient in a left lateral position, and I'll use a sim speculum.
Okay, what are all the things you look for?
So I'll look for evidence of atrophic vaginitis, urethral prolapse, pelvic organ prolapse, urethral diverticulum, and any evidence, for example, of fistula or uterine prolapse.
Okay. Examination wise, she's fine. She's quite symptomatic with frequency, urgency, and also as you questioning her, she says she also has some incontinence during the urgency episodes. How are you going to evaluate her?
The initial investigations that I asked for would be a urine dipstick analysis to exclude UTI, but also hematuria. I will perform residual bladder volume measurements in the clinic. I'll analyse a 3-day bladder diary, and I'll send off a midstream urine specimen for culture if indicated.
Okay. Is there any specific questionnaire available for these patients?
So if the patient is having incontinence, then there is the ICIQ short form questionnaire as well that can be used to provide an objective measure of their symptoms.
So, what are all the questions asked in that?
So this asks about questions related to the last 4 weeks. It asks the patient how often they leak, which scores from 0 to 5. How much they think they leak, which scores from 0 to 6. There's a third question asking about the level of bother on their life, which scores from 0 to 10. And then there's a final question which doesn't offer a score, but asks the patient about the situations and when they leak.
Is there any other questionnaire available in general for storage symptoms?
I think there is the overactive bladder questionnaire, but I can't remember what the components of that are.
Okay. And do you know what questions or how they assess it, or you want to leave it now?
I can't recall.
Okay, we leave it for now. Okay, her urine dipstick shows no evidence of any infection. She is scoring quite high in her ICIQ OAB questionnaire. We'll come back to that during the feedback session. Her blood investigations were normal. What further things you will advise her?
So I'll first of all advise from conservative measurement through lifestyle advice, which if applicable will include fluid modification to avoid bladder irritant beverages. I will advise on weight loss and smoking cessation if applicable. Given that she's over the age of 55, I want to ensure she has no atrophic vaginitis, and I'll therefore counsel about topical estrogen replacement if necessary. I will, however, also counsel about bladder retraining, providing bowels information leaflet on this, and also referring her to a pelvic floor physiotherapist to carry this out for a minimum of 6 weeks.
Okay. What advice the pelvic floor therapist will give her?
So they are likely to provide the same advice in terms of lifestyle measures, but they'll advise her as to the means of bladder retraining and the different ways this can be achieved. One of these could be asking the patient to void regularly every hour, even if there's no desire to void, but then on a weekly basis to prolong this by 15 minutes, thus retraining the bladder that the brain has control over micturition.
Okay. How will you explain Kegel's exercise to the patient?
So I'll explain to the patient that if this is to be performed, then they're to perform contractions of the pelvic floor as if they're trying to inhibit micturition, and that this should be carried out with at least 8 contractions at least 3 times a day and for at least 3 months.
Okay. And how will you define overactive bladder?
This is a clinical syndrome consisting of urinary urgency and frequency with or without urinary urge incontinence, and where there is an absence of any other pathologies.
How will you classify overactive bladder?
So this can be either dry with no incontinence or wet with associated incontinence.
Okay. What do you mean by Detrusor overactivity?
This is a urodynamic diagnosis characterized by the presence of involuntary detrusor contractions during the filling phase of urodynamics, and in which can either be spontaneous or provoked.
Okay. So you have advised her lifestyle changes and pelvic floor muscle exercises. Not much improvement. What is your next stage?
My next stage of management will be to counsel the patients about pharmacological measures, and this would be by starting off with anticholinergic medications. I'll counsel the patients about the potential side effects, including the dry mouth, constipation, blurred vision, and urinary retention. And I'll also ensure that she does not have any contraindications to treatment with this class of medications.
Okay, so what medication you're going to start her on?
So I will start her on solifenacin at a dose of 10 milligrams once a day.
Why not oxybutynin?
So the oxybutynin does have the lowest acquisition cost, but it also has the greatest effect on cognitive impairment. So given her age, I would be less inclined to start her on oxybutynin.
She's only 55. So what age you are a bit concerned when you are starting oxybutynin?
So it's a non-selective anticholinergic. So it has the potentially greatest effect on cognitive impairment.
Okay. If you are starting solifenacin, what contraindications you will be aware of?
So I want to ensure that the patient does not have a history of acute angle closure glaucoma, myasthenia gravis, that the residual volume is not exceeding more than, I think, 200 mils, and also that they don't have any history of bowel obstruction, active ulcerative colitis, or severe reflux or esophagitis.
Okay, so how are you going to review her?
Given that I am starting her on a new medication, then I will review her again in another 4 weeks' time with a repeat overactive bladder questionnaire.
Okay. The questionnaire shows she has only very mild to moderate improvement. Symptomatically, she is still struggling. What is your next step?
My next step would be to offer either an alternative anticholinergic. So the EAU guidelines outlined that in this scenario, the dose could be changed, but she's already the maximum dose, to offer an alternative anticholinergic, to add Mirabegron, or to switch to Mirabegron completely. So in this scenario, I will add Mirabegron onto a prescription.
Okay, we'll stop there, Piyush. Good presentation. Anything from your side before I give you the feedback?
No, I think the points to improve on would be the overactive bladder questionnaire and then how Kegel's exercises are performed. I think I'll probably modify my answer in terms of the initial anticholinergic. I think that the guidelines aren't very clear. They just say the lowest acquisition cost. But I'll have to modify what I do in practice to the exam. So probably I'll start with oxybutynin or trospium next time, and then I can move on to others.
Yeah, the best thing is not only for this table, in general. Number one, try to say what you do. Number two, try to substantiate why you do that. Both things. Okay. So you are tested on your knowledge, your clinical application, and your communication. Communication, you guys are absolutely fine because of repeated training, speaking. I think you will be hitting the ball absolutely clear. So how I will present this is, I will start the patient on solifenacin as my first choice. My dose of choice is 5 milligrams. After 3 to 4 weeks, once the patient is comfortable, if there are no bothersome side effects, the dose can be increased to 10 milligrams. At least 6 weeks trial should be given before we declare the medicine is not good for her or change the medication. I am aware that NICE guidelines, you need to bring NICE guidelines here. If you want to mention the year, it's 2019. As per the 2019 guidelines, I am aware that we need to use the drug with low acquisition cost. Oxybutynin is the one with low acquisition cost, but in my practice, we prefer solifenacin due to better side effect profile. So by this, number one, you are absolutely clear in your knowledge. Number two, you are proving that you are good in applying your knowledge to your clinical circumstances. Nobody can just follow NICE guidelines only. And in this process, you brought her age. NICE guidelines says you can't give oxybutynin immediate release for elderly women. So still you can give like slow release tablets in elderly women, and the woman what we are discussing is 55-year-old. She's not fitting into say 70s and 80s. So she's still suitable for oxybutynin. You can give solifenacin, but make sure that you bring your knowledge also. Don't get worried that I'm saying something but it's not in my practice, so you in the reflection said next time I will bring in oxybutynin. So examiner may play the card in a different way. Examiner will say, are you sure you definitely going to start oxybutynin for her? That's what do you do in the practice. Then you will take a back step and say, no, I will start on solifenacin. Isn't it? So the best answer is tell what you do and then substantiate with evidence saying that I am aware that NICE guidelines 2019 mentions about the low acquisition cost, which is oxybutynin in my area, in my deanery or whatever in my CCG. But I prefer solifenacin because of the side effect profile. That ticks all the boxes. Your knowledge, application of knowledge, both are ticked nicely. And just taking you back to the first question, include the past history of radiation. Very picky on that. You mentioned everything, but the radiation is the only thing you have missed out. UTI, again, you mentioned it. I'm happy with that. Estrogenization, you have mentioned. I mean, you haven't used the word estrogenization of vagina, but you said ruling out atropic vaginitis. That's okay. You should mention little thing about urethra, how the urethra looks. Is there any tenderness, scarring, masses, ruling out caruncle or anything like that? ICIQ OAB questionnaire. I know we are not doing that much in our practice, but from the exam point of view, I think it's nice to bring in. It is much more simpler when you compare to the ICIQ incontinence questionnaire. Just as you said, it's the same. Past 4 weeks are taken into account. 4 questions, fun and incontinence. Fun is
Yeah.
frequency, urgency, nocturia as usual. 4 weeks of history we are including in that, and all the questions were 0 to 4 again. So we are having a maximum score of 16, and
Yeah.
every element, fun and incontinence, also uh, measured by bothersome, which is not taken into account. So when you revise this session in the YouTube link, you will have the full questionnaire with the details of it.
Yeah.
And regarding the bladder training, the slight difference is, for example, if the patient has significant frequency of the symptoms, one of the component of bladder training is to purposefully hold the urine, divert the attention to something like, for example, reading or TV or music or something like that, so that you try
Yeah.
to hold the urine and gradually increase the functional bladder capacity. While you mentioned like starting passing urine every hourly and then slowly by timed voiding increasing the frequency or decreasing the intermittency of the frequency, while
Yeah.
that is good for patients with overflow incontinence or urinary retention or low pressure chronic retention, etc., where we want the patient to have timed voiding, and that too I think maybe like every 4 hourly may be a good thing to start rather than every hourly. But
Yeah.
for the patient with frequency symptoms, it's exactly opposite. You should try, the patient should
Okay.
hold the urine for longer time as a part of exercise. Kegel's exercise, you can teach the patient by saying you're as if you're holding to pass urine, or the easiest way is holding the flatus. That's more easier for patient to understand. It
Yeah.
is 10 times they need to do this and hold nicely for 10 times, and this has to be done in 5 sets. The easy way to do 5 sets is as soon as you get up in the morning after brushing, and every time before the meal, morning, afternoon and evening, and just before going to bed. So 5 times each as 10 set.
Yeah.
And there is a Bowes leaflet for comparison of treatment options for overactive bladder, like male LUTS information Bowes leaflet. You can bring that to that. Regarding the side effects of solifenacin, it is your side effects are correct. You can add hypersensitivity, that can be added for any medication, tamsulosin, finasteride, mirabegron, any medication. You can add hypersensitivity to the tablet. And the other thing is uncontrolled narrow angle glaucoma. You did mention narrow angle glaucoma, but if the narrow angle glaucoma is nicely controlled, we can still give solifenacin. So uncontrolled narrow angle glaucoma is the contraindication. I'm a bit picky because I want you to get the maximum outcome from the session, but presentation wise, absolutely fine. On the ball, I have no concerns as usual. You'll be absolutely fine.
Okay.
Anything from your side before we start the next scenario?
No, I think the only thing is that I presume that scenario would have then progressed into potential surgical management options, but you don't know how worried I should be about not getting to that part.
Yeah, first of all, don't worry at all. Not only in this table, in any table, once the table complete, there is no point in worrying that have I progressed till the appropriate questions what the examiner is interested. That is one of the least concern, and leave it as it's not of your concern. Number one, if you worry that during the exam period, that will have impact on your subsequent tables, which we don't want. Number two, if you worry that after your full day exam is complete, say next day when you're discussing with your friends, oh, I got this scenario in the female and functional urology, I progressed only till this, I don't know whether it's correct or wrong. There is no point in worrying. Anyway, done is done. Okay. So there is a scenario available just to discuss the evaluation of the storage symptoms or active bladder symptoms and the medical management. So you may be absolutely gone till the end of the scenario. So there is no point in worrying in that aspect. So leave that to your consciousness. Try to make the answers as crisp as possible without losing the major things, and which you're good. I'm very happy with that. So I don't think there is any point in worrying in that aspect.
Okay, thank you.
Good. Happy to start the other one?
Please do.
Okay. Your time starts now. You have a 28-year-old lady presenting with history of urinary leak on coughing. How are you going to evaluate her?
I'll see this patient in a dedicated functional urology clinic with a urology nurse specialist present, and I'll ask them to, prior to the appointment, to complete an ICIQ short form questionnaire and 3-day bladder diary, and also to arrive with a full bladder to provide urinalysis and a residual bladder volume measurement. I'll take a focus history to identify if the incontinence is triggered by urgency, stress, if it's mixed, or if it's constant and pointing towards an overflow incontinence. I'll ask about red flag symptoms, including a UTI, hematuria, back pain, and any bowel symptoms. I'll ask about the number of daily incontinence episodes, pad usage, and the effect on her quality of life. I'll establish her past medical history, including any previous pelvic surgery or radiotherapy, and also any previous childbirth and emergent delivery. I'll establish her medication history, and I'll also establish her tobacco usage and fluid intake. I'll perform a chaperone physical examination, measuring the BMI in clinic. I'll elicit any abdominal or loin pain, tenderness, or palpable masses, and then with the patient's verbal consent, I will place her into the left lateral position and perform an internal examination of the vagina and perineum using a SIM speculum, where I'll be looking to assess vaginal estrogenization, the presence of any pelvic organ prolapse, urethral diverticulum or fistulae, and also the peripheral neurological status.
Okay. Her predominant symptoms are just urine leak on, say, climbing up the stairs or laughing or coughing. Otherwise, she has no other overactive bladder symptoms. Examination wise, she's quite thin, and you are able to demonstrate urine leak on coughing during the speculum examination. So, what further things you can do?
So in the clinic, I would measure the urine dipstick analysis and measure the residual bladder volume, and also analyze the results of her questionnaires.
Okay, her questionnaire shows that she's quite symptomatic, and her post-ward residual volume is 10 ml. Urine dipstick is normal.
So I will first of all counsel about conservative and lifestyle measures to include modifying her fluid intake if necessary. If she has a BMI below 25, she would not need to lose any weight. But I will counsel her with regards to pelvic floor muscle training. And in order to do this, I will refer her to a pelvic floor physiotherapist so that she carries out the exercises for at least 3 months, and then is reviewed back in clinic in 4 months.
So, what is the role of BMI in this pathology?
So if there is a high BMI, this puts a increase on the intra-abdominal pressure, so that when the patient coughs, sneezes, or exerts himself, this pressure overcomes the urethral pressure that normally inhibits leaking.
Okay. This patient, as I said, there is no concerns with her BMI. Any other factors, and how are you going to take this patient forward? She attends your clinic after doing pelvic floor exercises in 6 weeks' time. She says only marginal improvement. She's following all the lifestyle changes which you have advised.
I will advise her that it's reassuring there's been some improvement. I'll advise her that she should continue these for at least another 6 weeks and up to a minimum of 3 months before demonstrable benefit can be seen.
Okay, you are reviewing her in 6 weeks' time. She has the same minimal improvement. There is no further improvement compared to the first 6 weeks. She wishes to have something more to be done.
I'll counsel about the next steps in management. The second line therapy, according to the 2019 NICE guidelines, includes duloxetine. So I will counsel her about this medication, and I'll talk to her about the side effects, including nausea and vomiting, drowsiness and somnolence. If she is not keen on this, then I will advise her that the next step in management would be surgical treatments. But in my practice, I'd want to carry out urodynamic studies prior to such an intervention.
Okay. And why do you want to do urodynamics? What is the evidence behind this?
So although the NICE guidelines do not advise urodynamics prior to primary stress incontinence surgery, in my practice, I would want to rule out Detrusor overactivity as a cause of incontinence, because this would then have an impact in terms of potential postoperative complications and ongoing leakage despite surgery being carried out.
If she has detrusor overactivity, do you expect any other coexisting symptoms other than the pure stress urinary leak?
One would also expect there to be urgency, frequency, and urgent incontinence.
Okay, but she's presented only with stress urinary incontinence. Okay, your urodynamics shows that our filling phase is absolutely quiet. There is no signs of any detrusor, hypercontractility, or overactivity. She leaks whenever she coughs. Her voiding pattern is acceptable. She voids completely with the bladder emptying. What is your next step?
I'll discuss this patient at a local MDT, and this will be to discuss the role of surgical management, and the options to be offered to her would include autologous fascial sling insertion, birch copper suspension, or intraurethral gulping agents.
Is there any way you can choose between these three options?
So this could be also depending on the type of stress urinary incontinence, and also whether it's due to intrinsic sphincter deficiency or bladder neck or urethral hypermobility. The way to determine this would be through performing video urodynamics to obtain a blade mass classification.
So how video urodynamics help you in differentiating these two conditions?
So with video urodynamics, a cystogram is obtained, which will then help to determine the level of the bladder neck and urethra relative to the inferior border of the pubic symphysis. Grade 0, so between grade 1 is the descent of the bladder base less than 2 centimeters below the inferior border of the pubic symphysis, and this would be more in keeping with an intrinsic sphincter deficiency. Grade 2 is descent of more than 2 centimeters. Grade 3 is when there is when the bladder neck and urethra are already open. And sorry, that would be more intrinsic sphincter deficiency. Below 0 and 1 is more hypermobility.
Okay, so if your finding is say hypermobility, what is your choice of treatment?
So this would be the choice of treatment. There would be a birch copper suspension.
Okay, how will you counsel her?
I'll counsel her with the aid of a Bowes procedure-specific patient information leaflet, outlining the benefits in terms of treating her stress incontinence, how the procedure is performed with mobilization of the bladder, and sutures to suspend it into a higher position in the pelvis. And I'll outline the complications with specific ones, including failure of the procedure, voiding dysfunction, middle or posterior compartment prolapse, UTI, retention needing ISC, and also de novo urgency.
What do you mean by middle component prolapse?
So this would be, think uterine prolapse, or posterior compartment prolapse would be also a rectocele.
Okay, what sutures you will tie? What suture material you will use?
So I will use a 3.0 PDS, which is an absorbable suture but longer acting.
Okay, so what structures you will suture?
So I'll suture the bladder wall. I can't recall the other structures to suture to.
Okay, we'll come back to that. In case if your urodynamic findings are suggestive of intrinsic sphincter deficiency, what is your choice of surgery?
So this would be an autologous fascial sling.
Okay, we'll have one more question. So what type of slings you will choose? Why are you not selecting the usual TVT, TOT?
So my choice will be a graft harvested from the rectus fascia, measuring 10 by 2 centimeters. I'll avoid the synthetic mesh because there's currently a pause on the use of these in the NHS due to the findings of the Cumberland report and the incidence of mesh complications.
Okay. Any other sources of autologous fascia harvesting?
I think from the fascia lata.
Okay. One more question to finish. What is your indications for Bulkamid or injection therapy?
So according to the NICE guidelines from 2019, these would be where the patient is not suitable for more extensive surgical management or is not willing to have the other procedures performed, and it may be reserved for patients who may be too elderly, too frail to undergo general anesthetic.
Good. Yeah, elderly is a good choice because elderly patients, again, colpo suspension or autologous fascia surgery, everything is more complex for them. While this will give them a nice temporary relief, and even if it gives relief for them, say for 2 years, then they can have a repeat injection therapy also. So sometimes you may have to get a little bit more about this injection therapies, how it is injected, what is the material, etc.
Yeah.
Second scenario, much better, but as usual, very straightforward scenario. Again, you are mentioning ICIQ short form. ICIQ short form is a bit of a very generic term, so try to specifically mention ICIQ OAB, ICIQ incontinence form, ICIQ male LUTS. So try to expand it further to say which ICIQ, because there are at least 5 to 7 ICIQ short forms available now. Again, the controversial topics, the same discussion like how we discussed in the first scenario. NICE guideline says there is no need for stress urinary incontinence in pure, no need for urodynamics in pure stress urinary incontinence. But in my practice, I prefer to do that because number one, it will help me to differentiate the intrinsic sphincter deficiency and hypermobility, which is a good point.
So then in that, I mean, again, it's not specified NICE guidelines, but then for stress incontinence, you'd be looking at video urodynamics, wouldn't you?
Yes.
So you need that cystogram.
Yes, instead of cystogram, it's a video is not a very big addition. Most of the units will have a kind of a CM in situ, and only the voiding phase you're just going to screen it to document it in video. So if you are substantiating your practice, which is slightly different from NICE guidelines, you need to really bring a strong point in that. So the points to support doing urodynamics are, number one, in my unit we have video urodynamics, so we prefer to do them as a part of preparation for the surgery, which help us to differentiate between intrinsic sphincter deficiency and hypermobility, which also have impact in choice of surgery. And number two, we have a strong MDT, and while presenting the MDT, this will help me to produce a nice substantial evidence for her surgery. And number three, in the previous era, when we are subjecting to the patient to the artificial slings, it's very important to document this finding because of the complexity associated with TVT and TOT. But in my practice, I've stopped it now, and we are doing only autologous fascia. So all the more reason you have good practical clinical support to do urodynamics. But you can say the NICE guidelines, according to the NICE guidelines, if the patient has symptomatic pure stress urinary incontinence, usually the urodynamics won't add anything because we expect the Detrusor to be good. Okay?
Yeah.
Good. Happy to start another scenario?
Yes, please.
Okay. Your time starts now. Let us continue from the first scenario where you have tried solifenacin, but the patient was not very happy with the treatment, and coming back to you, you are trialing your second choice. What is your second choice?
This will be Mirabegron.
Okay. So how will you explain Mirabegron to her? What is Mirabegron?
So Mirabegron is, I'll explain to her that it's a beta-3 agonist, which works via the activation of beta-3 receptors in the detrusor muscle to enable relaxation of the bladder as opposed to inhibited contractions. And I will ensure that this patient also does not have any contraindications to it.
Okay, what are the contraindications?
So these are an uncontrolled hypertension where the systolic blood pressure is greater than 180 millimeters of mercury, or the diastolic is greater than 110 millimeters of mercury. They also include severe hepatic impairment, a GFR of less than 15, and breastfeeding.
Okay, if there is liver or renal impairment, is there any way you can still help the patient with Mirabegron?
So if the GFR is between 15 to 29, then the dose can be halved to 25 milligrams once a day.
Okay, so what advice you will inform the patient's GP?
So I'll ask them to check the blood pressure at baseline and then at for 1 week and 4 weeks, and that if the blood pressure does increase to above the thresholds mentioned before, then to discontinue Mirabegron and wait until further review by myself.
Okay, what are the side effects of Mirabegron?
The main ones are high blood pressure, UTI, and nasopharyngitis.
Okay, so is there any way you can improve her symptoms by giving any combination treatment in case if she comes back in 6 to 10 weeks and says that Mirabegron also not giving a good complete relief?
So it can be combined with solifenicin, either 5 to 10 milligrams once a day.
Okay, any evidence to support that?
This is from the Synergy trial, which looked at various combinations of either solifenicin or Mirabegron monotherapy, combination therapy compared to placebo, and this was used for both dry and wet overactive bladder, and it found that combination therapy between 5 milligrams of solifenicin and 50 milligrams of Mirabegron reduced the number of mean daily urgent incontinence episodes and was superior to solifenicin monotherapy.
Okay, she is trying the combination, but you are reviewing her in 3 months' time. She has not much improvement, only very marginal improvement in the scores, but symptomatically, subjectively, she is quite symptomatic. What is your next step?
So my next step in management will be to request urodynamic studies for this patient to confirm the presence of the Detrusor overactivity prior to discussion at local MDT to consider surgical management options.
Okay, what are you expected to see in urodynamics?
So during the filling phase, I'm expecting to see evidence of the Detrusor overactivity and possibly evidence of urinary urge incontinence, a small bladder capacity as well, and a normal voiding phase.
Okay, if the findings of urodynamics supports presence of Detrusor overactivity, what is your next step?
I'll discuss this patient at a local MDT with the recommendation to offer her intravesical Botox injections as first-line treatment.
So what is Botox?
This is Botox refers to Onabotulinum toxin A, which is derived from the bacteria Clostridium botulinum. There are 7 serotypes, of which A and B are used clinically, and the mechanism of action of Botox is to inhibit the fusion of acetylcholine containing vesicles to the presynaptic membrane of the neuromuscular junction, and to therefore inhibit bladder contractility.
Okay, so how are you going to counsel her for Botox?
I'll counsel this patient with the aid of a Bowes procedure-specific patient information leaflet, outlining the benefits in terms of treating her overactive Detrusor overactivity. I will outline the alternative management options, including sacral nerve stimulation and posterior tibial nerve stimulation, and outline to the patient how this is carried out in terms of cystoscopy and injection of Botox into the bladder wall, and I'll outline the risk of the procedure with specific ones including UTI, bleeding, the need for repeat injections, and also urinary retention, which requires her to be taught intermittent self-catheterization prior to undergoing the procedure.
So what is the dose you will advise her?
I will advise her that she should have a starting dose of 100 units as per the 2019 NICE guidelines on incontinence.
Okay, so take me through the procedure on the day when she is consented and ready.
So I'll ensure the patient is appropriately prepped, consented, and anaesthetized, and I'll perform it under a general anesthetic. I'll ensure that when she arrives, she has a urine dipstick performed to exclude UTI. I'll perform a WHO checklist to include appropriate VT and antibiotic prophylaxis. I'll place her into a lithotomy position, prep and drape the area, and I'll insert a size 22 rigid cystoscope into the bladder, performing cystourethropy. I will ensure that I've drawn up the Botox myself in 10 mils of normal saline, so that there's 10 units per mil, and I'll then administer 20 injections of 0.5 mils throughout the bladder, sparing the trigone and the UOs, and that the bladder is emptied satisfactorily at the end of the procedure. I'll devise a post-op with clear immediate post-op and long-term follow-up instructions.
Okay, procedure went well, but in the post-op she was not able to pass urine and she ended up having retention. What is your advice?
My advice would be that if this patient had been taught intermittent self-catheterization, to see if she can attempt it herself, although if she's still recovering from the effects of the anesthetic, I would advise that she have an indwelling catheter inserted. Prior to discharge, she should have an attempt at a TWOC, but if this is unsuccessful, then she should perform ISC and be reviewed by myself in 6 weeks.
Okay. Is there any reason you need to increase her dose of Botox in the next time? How will you arrange a follow-up?
So I'll arrange for her to be followed up in 12 weeks to assess the response. I will provide her with contact details of the department so that if she's not experiencing any improvement at all by 6 weeks, then the dose she should be considered for repeated injections at an increased dose. And again, at the 12-week review, if there was initial improvement but the symptoms are starting to come back, this would be another indication as per the NICE guidelines to increase the dose to 200 units.
Okay. Do you know any studies to support Botox in OAB?
There is one study there are two studies which were EMBARK and Dignity. EMBARK looked at the use of Botox in idiopathic DOA, and Dignity was a neurogenic DOA, and both of them found improvement in mean daily urgent incontinence episodes compared to placebo.
Okay. So let us assume that after the first injection of Botox, she got quite upset with the whole Botox phenomenon because of the urinary retention and need for intermittent self-catheterization. What is the next choice for her?
So the next choice to offer her would be sacral nerve stimulation.
So how it works?
So this works through the placement of a lead into the S3 foramina. This is then connected to a electrical device and stimulator, which is placed underneath the skin. And this essentially modulates the activity of S3 in terms of producing bladder contractions.
Okay, so how are you going to explain this to her?
I'll again explain it to her with the aid of a procedure-specific information leaflet. I will inform her that the procedure is carried out initially with a test implant, which is attached to an external generator. She has to keep a bladder diary for up to 2 weeks, and she can then only proceed to the full implantation if there is at least 50% improvement in her symptoms.
Okay. Do you know any evidence for sacral neuromodulation?
There was the Rosetta trial, which compared it to Botox in the management of idiopathic DOA, and this found that it was as effective as Botox in terms of symptom improvement and reducing mean daily urgent incontinence episodes, but it had a much lower incidence of UTI retention and less than 10% chance of explantation.
Any other options available other than sacral neuromodulation?
So the other options, if the patient's not keen on surgical management, would include posterior tibial nerve stimulation, and further options beyond this would be augmentation, cystoplasty, or urinary diversion as a last resort.
What do you know about cam cystoplasty?
So clam cystoplasty involves the interposition of a segment of ileum onto the bladder after it's been bivalved. And this is with the aim of reducing the detrusor contractility, reducing the detrusor pressure, and also increasing the bladder capacity.
Okay. What do you mean by Detrusor myomectomy?
So this would be the incision. Sorry, I don't know.
Okay, we'll stop there. As you heard, there was the 10 minutes finished. At least we have discussed almost a minute overrun. So Detrusor myomectomy is nothing but bladder auto-augmentation. So we are incising a portion of the detrusor muscle. It could be just an incising or excising the detrusor muscle and creating a pseudo diverticulum. The disadvantage is sometimes it's good in reducing the bladder storage pressure and increasing the bladder capacity, but in long term the pseudodiverticulum can get fibrosed and sometimes it's not useful. The other thing, as you said, is the urinary diversion. So detrusor myomectomy is another thing which you can keep under your sleeve to help. Posterior tibial nerve stimulation, when you're explaining, please do mention that it is not supported by NICE guidelines as of now. If at all, if you're doing, it has to be under the local MDT review and should be under a proper trial, not open practice. It's still under trial.
Okay.
Yeah. Let me take you back to the starting and then slowly let us come down. I think we discussed few things. I'm happy with your synergy trial evidence. Synergy trial used solifenacin 5 milligram and Mirabegron 50 milligram. So no 10 milligram were used, but in few patients solifenacin 5 milligram and Mirabegron 25 milligram were used based upon the hepatic and renal function. Some surgeons believe that you can give up to Botox without urodynamics, but nothing wrong in saying I will do urodynamics before any intervention. Medications, no urodynamics. Once we have to go for Botox, it's better to have urodynamics. You have missed intermittent self-catheterization teaching before Botox, so that is very handy for the patient to learn. In case if she needs post-op, it's easy to counsel and you don't have to place the patient on catheter. She knows the ISE means she can just do the ISE and she's aware that she may have to do that anyway. Regarding how the Botox works, it has heavy and light chains. So heavy chain binds to presynaptic nerve endings and that helps the toxin to be internalized, and light chain cleaves SNAP25 that blocks the exocytosis of acetylcholine. So heavy chain, light chain. Heavy chain helps in the endocytosis and light chain cleaves SNAP25. Bit mouthful, but the terminology is just take a note of it and try to keep in your revision cards. Botox can be done under local anesthesia, not necessarily every time under GA. Nothing wrong in saying GA, but it's nice if you can mention that I'm aware that some surgeons are performing this under local anesthesia with flexible cystoscopy and flexible the needle guide. Prophylactic antibiotic gentamicin is contraindicated. It's nice if you can bring on your own and mention that you will give, say, ciprofloxacin or some other things, so that it's nice to bring those practical things which gives a confidence.
I suppose I could say antibiotic prophylaxis, but this would not be gentamicin.
Yes. Yeah. So this gives the examiner a confidence, okay, he definitely has attended the session, he's not just saying from the books. You can bring urology nursing team both in the medications time, urodynamics time, and also as a key contact person after Botox. You
Yeah.
said I will give the urology number, which could be your secretary's number. Secretary can't help clinically. Urology nursing
Yeah.
team will be quite handy, or you can label it as a continence team also.
Yeah.
Yeah, otherwise it's good if the patient is responding well to Botox, but if the effectiveness is not holding on till 6 months, then there is a indication to increase the dose to 200 units. While
Yeah.
for neurogenic Detrusor overactivity, you will give 200 units from the starting.
Yeah.
EMBARK study is a good one to mention, and also the synergy study, or the two main studies. I'm not really bothered about the studies, but if you are at a good stage, so I wish you to be confident in the studies also.
Yeah.
Good. Any suggestions, feedbacks from yourself before we conclude?
No, I don't think so. I think it's just been useful to fine tune some of those things.
Yeah.
And yeah, certainly in terms of, I suppose, doing these 10-minute sessions, they do go by quite quickly. So, yeah, I'm happy. I think I'm satisfied with my knowledge.
Of course.
And I have been getting evidence from papers in and just reading the summaries, and I'm pretty. That is something I want to definitely aim for.
Good. I think you're in a perfect stage. The only advice I will say is have two A4 sheets for every table, and start mentioning, for example, EMBARK, synergy. You don't have to even mention what is inside, and or maybe in a small few values here and there, so that you will create two A4 sheets. Usually there will be a gap between the tables, so you know what table you are going to. Just take only these two A4 sheets and glance through that values and definitions, and maybe like nice 2019, those things, so that it will come exactly when you need it. Because you need to bring the things exactly in the 10 minutes. That's the main goal of the full teaching. That can happen only by having your own handwritten notes. If you are maybe like a iPad or Mac user, again you can create a good one slide or two slides maximum, so that you don't have to go through your main reading books or guidelines in the exam day. Okay.
Yep.
Good. And since you're on study leave now, we have more flexibility. I will try to give you some more sessions in the next weekdays.
Yes.
Good. Have a nice rest of the weekend.
Thank you very much. I'll be in touch.
Good. Bye.
Bye-bye.